So the theme for today's talk is going to be on germ cell tumors, and we have the pattern of this talk would be, there'll be a talk by Dr. Tarang Vora, uh, followed by two case presentations by our residents, which will be discussed by the other resident, and which will be then commented upon by our panelists. And finally, there will be another talk by Dr. Ved Prakash. So first, I would like to begin by introducing our panelists. We are really honored to have Dr. Girish Menon, the former head of neurosurgery of KMC Manipal and editor-in-chief of Neurology India with us. Welcome, Dr. Girish.
Thank you, Ranjit.
Yeah, then we have Dr. Rajesh Balakrishnan, who's professor of radiation therapy at CMC Vellore with special interest in neuro-oncology. And welcome, Dr. Rajesh. And we have Dr. Aarti Vishwanathan, the consultant pediatric hematologist and BMT specialist from Sri Shankara Cancer Hospital and Research Center in Bangalore. Welcome, Dr. Aarti.
Thank you,
to
sir.
our panel.
Yeah, thank you.
Yeah. So first speaker is going to be Dr. Tarang Vora. Tarang Vora is a consultant neurosurgeon who did his special interest in pediatric neurosurgery, who did a fellowship in CMC Vellore in pediatric neurosurgery, and also another fellowship in AIMS Delhi. So he works in Apollo Hospital, Hyderabad, and he will be talking to us on an approach to a patient with suspected germ cell tumor, focusing on clinical diagnosis, imaging, and role of tumor markers for the next 15 minutes. Dr. Tarang, you can share your screen.
Sir, it says host disabled participant sharing screen.
Mr. Santosh, can you check on that?
Yes, sir, sure, sir.
Yes, sir.
Yeah.
Yes.
Now you can share.
Okay. Is my screen visible, sir?
Yeah, its screen is visible. You may have to. Okay, you're in slideshow mode. Yes.
Okay,
we can see your screen. We can hear you.
Sir. Okay, sir.
Please go ahead.
All right, sir. So I will go directly into the talk. So there are four types of intracranial germ cell tumors. 5 types of intracranial germ cell tumors. One is germinoma, that is the most common type, followed by embryonal carcinoma, yolk sac tumor, choriocarcinoma, and teratomas. Out of the 5 types that we have the germ cell tumors are divided into 2 subtypes. One is the germinomatous group, that is germinomas, and the second subtype is non-germinomatous germ cell tumors, which account for 35 to 45% of germ cell tumors that are intracranial in origin. The I in before GCT stands for intracranial. So the question is, what are germ cell tumors? So basically, to answer that, they are basically tumors that are arising from primordial germ cells. So when we're looking at this slide, we have the blastocyst followed by the gastrulation that is happening from the bilaminar disc. And in that slide, in the second, that is happening, gastrulation happening in the second week, between the epiblast and the hypoblast, we have some red color cells, and those are the primordial germ cells. These are totipotent cells who move out from that area and go out and sit somewhere near the yolk sac. And once the gastrulation is completed, they go back inside, and then their main job is to form the ovaries and the testes. And because they are pluripotent, and then they form the gametes and zygote, and the reproductive cycle keeps on going back in again and again. So the point is that these cells are responsible for forming ovaries and testes. What are they doing in the brain? So these are basically meant to go near the genital ridge during the embryological phase. They move out and go back inside the body. The question is how the organs, the cells that are responsible for forming testes and ovaries, and what are they doing in the brain? So some of these cells, they can migrate along the tissue in a different direction due to different types of mutation. And if they do happen to migrate in a different direction if they go towards from the midline and they reach the areas which whose development is slightly abnormal. So like for example, the pineal region is not only of neural ectodermal origin, it is of neuroectodermal origin as well as some non-neural elements to it. Similarly, the suprasellar region also has some neuroectodermal origin as well as non-neuroectodermal origin. As we know that the Rathke's cleft cyst is from the surface ectoderm and the upper part is from the neuroectoderm. So in these areas, these cell rest, if they are remaining during the embryonical life, then in later, if they are hit again and they multiply and they form as germ cell tumors. So depending on where the germ cell tumors are and what subtype they are, there are different types of germ cell tumors. So these germ cell tumors are pluripotent stem cells. Basically, they can divide and form anything that they wish into. So if they divide and mimic a yolk sac, then it will become a yolk sac tumor in the brain. If they divide and mimic into the placenta or chorion, then it becomes a choriocarcinoma in the brain. Both of these are extraembryonal, as in the yolk sac and chorion are not part of the embryo, whereas the teratoma and the embryonal carcinoma are embryonic, and that is why they are called as embryonic types of germ cell tumors, because they are trying to mimic. If they are trying to mimic a blastocyst, it will become an embryonal carcinoma. If it is trying to mimic something that is very well formed, then it will form a teratoma. What about germinomas? When they are not trying to mimic anything, these PGCs or these germ cells, pluripotent germ cells, they when they are not mimicking anything, just multiplying, that is what we call as germinomas. So when we look at a histological point of view, they look like a chorion and choriocarcinoma, yolk sac in a yolk sac germ cell tumor. Teratoma will look like well-developed body tissues, and the embryonal carcinoma will look like a blastocyst. Whereas if they're looking only as like PGCs, then they are germinomas. Epidemiologically, germ cell tumors are more common in Asian region, very rare in Africans, and more common in less common in the Western population. The most common age group is between 10 to 20 years. So these are adolescents or young adults presenting to us with a male preponderance. The most common site is pineal, followed by suprasellar, and the rarer sites like basal ganglia and thalamus all are in the midline location because the PGCs will migrate there. Types we have already discussed. Clinical presentation. So depending on where this tumor is growing, the clinical presentation will vary. So if it is in the pineal region, we will have Perinaut syndrome and hydrocephalus if there is obstructive hydrocephalus developing due to the aqueductal compression that is happening over there. Suprasellar, if it is in that area, then it will probably have diabetes insipidus, hypopituitarism, visual field defects, depending on how far it is growing. We may get a bitemporal visual field defect because of it. If it is in the basal ganglia, the patient may present with hemiparesis or a cognitive decline. Sometime HCG secreting tumors, the patient can have precocious puberty because of oversecretion of HCG. I will not go so much into algorithms as Dr. Ved is going to discuss in details about algorithms. So I have removed all the slides that are having algorithms in my presentation. So, but basically, if a patient is coming, we're looking for clinical symptoms of raised intracranial pressure. We're getting the MRI brain and spine imaging because these can travel. We're looking at serum and CSF tumor markers. We're looking at CSF cytology, and then we go ahead with surgery if needed. The intention of having a discussion dedicated towards germ cell tumors is that it is now more evident that it is not so much surgical, but chemotherapy and radiation, which may play a very central role in treating these diseases. And our role as surgeon probably is now limited very much to biopsy in also certain cases and not most of them. So moving on to the role of tumor markers. So beta HCG is elevated in choriocarcinoma. We're looking at three types of tumor markers. One is beta HCG, one is alpha fetoprotein, and last is PLAP. PLAP is not routinely available in all labs. So the two most common tests that we order to a patient where we are suspecting a germ cell tumor, that would ideally be in between 10 to 20 years of age and having a mass in the pineal region, would be a serum beta HCG and a serum AFP, as well as a CSF beta HCG and a CSF AFP. When we are doing both, our sensitivity and yield increases. So both choriocarcinoma as well as yolk sac tumor will have an elevated beta HCG. Beta HCG is elevated in choriocarcinoma, but mildly elevated in germinoma in very few cases, whereas AFP elevated, I have written NGGCT, but it is predominantly yolk sac tumors which have an elevated alpha fetoprotein levels. PLEP is now considered as an adjunct for diagnosis in germinomas if the testing is available in the lab. In our hospital settings, we don't have PLEP available. The diagnostic thresholds that are there for us to say that, yes, this is positive would be around 50 international units per liter for beta HCG and 25 nanogram per ml for alpha fetoprotein to be saying that it is positive. AFP more than 1,000 is suggestive of a case which has extremely poor prognosis and probably not a very good candidate for surgery. So when we're looking at diagnostic markers in cases of intracranial germ cell tumors, again, this is just a summary of what we have discussed previously, mentioning some amount of sensitivity. So when we're looking at CSF in pure germinomas, we will get placental alkaline phosphate is the only marker. Beta HCG can be mildly elevated in cases of germinoma. So even if it is elevated in some cases, we need to know what is the level, how much is it elevated, and we need to know PLAP levels, whether it is germinoma versus choriocarcinoma. Choriocarcinoma as well as yolk sac tumors, it has been recently noted. It was initially noted that CSF is probably more sensitive, but there are recent articles which suggest that serum levels of beta HCG as well as serum levels in yolk sac tumors, AFP, sometimes yields higher results. So there is some debate over there whether serum is better or CSF, but in general practice, it would be better to send both so that we get an overall good yield of it. Embryonal carcinoma, we don't have that much of markers, but it can be a general mix depending on the constitution of the cell growth that we are having. In a mixed germ cell tumor, we may have a variable appearance. In teratomas, of course, there are no germ cell markers that we are, tumor markers that we are looking for. So in general, PLAP for germinomas, beta HCG for choriocarcinoma or germinomas, and AFP for yolk sac tumors or embryonal tumors. The sensitivity is highest for AFP. So like if an AFP is positive, we are pretty sure that is non-germinamatous and it is more likely to be a yolk sac tumor. Same with beta HC. The lowest sensitivity we have is for PLAP, in which the CSF in the serum is like very, very low. So in summary, for the tumor markers, we have always to check for CSF markers since they are known to be more sensitive, and serum markers both in most of the cases. Normal AFP and plus beta HCG with PLAP positive is strongly suggestive of pure germinoma, which is not a surgical disease from the neurosurgeon's perspective. Elevated AFP or marked elevated beta HCG are probably points towards a non-germinomatous or a mixed germ cell tumor. We don't know which subtype it is, but with very high elevated levels of beta HCG is more strongly suggestive of choriocarcinoma, and a more highly elevated AFP suggesting of yolk sac tumor. PLAP immunostaining is also available on biopsy tissue, and it is positive in 90% of germinomas. Moving on to the imaging part, which is the most crucial part from a neurosurgical perspective. So in general, when we are looking at a child's MRI who has come with a pineal region or a suprasellar region mass over there, we are looking at what kind of enhancement is there. So the most important, three important things we are looking at. One is enhancement, second is diffusion restriction, and third is the perfusion. Even though I have not meant the perfusion part is not mentioned in this slide, the enhancement is very important because all germinomas will enhance homogeneously. Predominantly, of course, there is variation, but most of the germinomas will have a homogeneous enhancement. Whereas the non-germinomatous germ cell tumors will not have a homogeneous enhancement, will have an irregular enhancing pattern. The diffusion restriction is present in germinomas, but the diffusion restriction is variable in the non-germinomatous germinomas. So if the enhancement is heterogeneous, the diffusion restriction is heterogeneous, then we're looking more like a non-germinomatous germ cell tumors, whereas the enhancement is homogeneous and the diffusion restriction is good. Along with that, we have low perfusion on the perfusion weighted images. Then we know that it is a germinoma and we just need to send it across to our colleagues in oncology. But if we have a heterogeneous pattern and the diffusion restriction is variable and the perfusion is high, then we know it's a non-germinomatous germ cell tumor. And therein, we are looking for more of the CSF markers. And if they are positive, we still again are sending it back to our oncology colleagues. So looking at going through few radiology images just to brush up on how it looks. So this is a homogeneously enhancing tumor in the pineal region. We are looking at the image of T1 and T2 weighted images. We are seeing the diffusion restriction that is present in the bottom left image. So diffusion restriction plus homogeneous enhancement. We are looking, and this looks like a germinoma on radiology. Again, diffusion restriction with this is a homogeneous contrast enhancing tumor in the suprasellar as well as the pineal region. So this is bifocal. Bifocal means there are two tumors looking similar in the suprasellar as well as in the pineal region. This is pathognomic for germinoma. So if we're seeing bifocal tumors which are homogeneously contrast enhancing, we can be like very, very highly certain that these are germinomas, probably not needed for biopsy. There are a lot of publications which say that biopsy is not needed for bifocal germinomas. There is a black spot that we are seeing on the imaging in the center, and that black spot is nothing but calcification. And that calcification is what we call as an engulfed calcification. Again, bifocal type of germinomas, homogeneously contrast enhancing lesions in the suprasellar as well as the pineal region, are pathognomic of germinomas. No biopsy needed is the current consensus, but it is debatable. Perfusion imaging. This is a perfusion imaging of a child with germinoma. In the bottom row, you can see that it is hypoperfused. It is not looking red. It's bluish in color, the same tumor region, which is again suggestive of germinoma. This is a child with germinoma with a central calcification. This central dot calcification is what we call as an engulfed calcification. Again, germinoma. So patterns of calcification in pineal tumors slightly different. Engulfed calcification is more pointing towards germinoma. Exploded calcification is looking at other pineal region tumors like pineocytoma and pineoblastoma. Choriocarcinoma. So now these are tumors which are known for bleeding. So it's made from chorion, nice blood vessels. So they are going to bleed. On a CT scan, if you have seen a blood intensity, not a calcification intensity tumor, then you know it has bled. These are heterogeneously contrast enhancing, will look highly vascular to us. We do the CSF analysis, we may see beta HCG. Again, this is susceptibility weighted imaging on the top left and GRE images, which is showing that it has bled over there, which are suggestive of choriocarcinoma. When we're seeing hemorrhage in a germ cell tumor, we are thinking choriocarcinoma. Yolk sac tumor, these are extremely aggressive tumors compared to the rest of them. They'll be slightly huger in size. Again, things that is pointing is that it is heterogeneously enhancing. The diffusion restriction is heterogeneous, again, non-germinomatous. And you're looking at the image at the bottom right, it is hyperperfused. It is looking red in color. Hyperperfusion points towards non-germinomatous germ cell tumors and not towards germinomas. Teratomas, this is a plain T1. This is not a contrast image. You see fat in any of the tumor on T1 weighted image. you know it's a teratoma, probably a germ cell, but a mature teratoma carries one of the best prognosis. After germinoma, the next germ cell tumor to have a good prognosis would be a mature teratoma of the same location. Last point about radiology is that how to look for diabetes insipidus, whether the child is symptomatic on radiology. We're looking at the hyperintensity on a T1 weighted image of the posterior pituitary. If it is hyperintense, then the posterior pituitary is doing well. As soon as the hyperintensity of the posterior pituitary is lost, DI the DI has actually manifested for that child. So it correlates very nicely with radiology. If the posterior pituitary is no longer having hyperintense streak on T1 weighted, it is DI that has already manifested. So lastly, about differential diagnosis for the radiology, of course, we have craniopharyngiomas, which will be cystic, calcified in the suprasellar region, will not have the tumor markers. Hypothalamic gliomas will be solid T2 hyperintense. All of these germ cell tumors are T2 hypo and not T2 hyper. Of course, if there is blood, then the appearance does change. There is no enhancement of hypothalamic gliomas. These germinomas enhance beautifully. Lymphomas are homogeneous with some restricted diffusion, but they are periventricular in location, more along the lateral ventricles. Pituitary stalk thickening can be sometimes confusing. MRI brain features for germinoma is that it is ISO2 hyper in T1, ISO2 hyper in T2, homogeneous enhancement, diffusion restriction, low perfusion. NGGT is heterogeneous, cystic, necrotic, high perfusion, poorer prognosis, uh, uh, variable restriction. Multifocal lesions, if you have two lesions, one in the suprasellar region and one in the spinal region, more
Dr. Tarang,
likely
you
to
need to
be.
wind up.
Yes, sir. I mean, the last few slides, sir. Okay, sir. So the last part of the imaging towards the bifocal lesions are germinoma, engulfing calcifications, germinoma, hemorrhage, choriocarcinoma, fat teratoma, restrictive diffusion is germinoma, low perfusion germinoma, high perfusion non-germinomatous germ cell tumors. So in summary, uh, these are midline endocrine tumors. Uh, we require endocrine consultations for these tumors because they may have DI. We are looking at visual and raised ICP symptoms. Imaging, I have gone through the midline enhancing lesions plus minus calcification. Markers are beta HCG and AFP predominantly. If PLAP is available at your institute, CSF cytology and markers, and biopsy is something that Dr. Ved will discuss. This is my last slide, and that's the end of my presentation.
Thank you, Dr. Tarang, for summarizing that and giving an introduction of germ cell tumors. Now we shall move on to the next talk, which will be a case presentation by Dr. Javia Vanit Rajlal from PGI Chandigarh, and who's been guided by Dr. Karthikeyan for this presentation. So he will present the case, and then the case will be discussed by Dr. Nivedita. Dr. Nivedita, are you ready?
Yes, sir. I'm ready, sir.
Okay.
Hello, good evening. I'm ready.
Yeah, good evening. Dr. Rajlal, you can start.
Yes, sir.
You can share your screen and start.
I would encourage the residents and others to ask any queries and doubts. And you can put your queries in the chat box so that it can be taken for discussion.
Okay.
You can start,
Good evening, sir. Okay. Good evening, sir. I'm presenting a case. A case of a 15-year-old boy who presented with complaint of raised ICP, that is headache and vomiting, since last 10 days, and complaint of intermittent blurring of vision. There were no history of any seizure or focal motor or sensory deficits. There were no history of cognitive or behavior changes.
The slides are not moving. I am not sure.
I think your slides are not moving. Yeah.
Okay.
Yeah. Go ahead.
So on examination, patient was E4, V5, M6, vital stables within normal limit. Pupils were 3 mm equal and reactive to light. Endoscopy showed bilateral papillary edema with grade 4. And there was upward gaze paresis with mild gait ataxia. So initial CT showed the hypodense heterogeneous mass occupying the entire third ventricle and extending into the left lateral ventricle with punctate calcifications with upstream hydrocephalus. We did an MRI T1 and T2 image, which is showing a heterogeneous mass that is which can be seen in sagittal and film, that it is occupying the entire third ventricle and anterior and posterior third ventricle and extending to the left lateral ventricle with hydrocephalus. This is the coronal image showing this. So I would like to discuss what were with Dr. Nivedita, what differential diagnosis she would like to put in here.
Can you just put up the sagittal images so everybody can see
Yes,
that while she's
yes,
discussing this? Yeah.
Yes, sir.
Yeah, Nivedita, go on. Go ahead.
Yes, sir. So it's a child who's presenting with obstructive hydrocephalus, as well as the MRI imaging basically shows a lesion which is present in the posterior third ventricular lesion, and it is also extending into the atrium of the left lateral ventricle as well. Based on this, my diagnosis would be a pineal lesion tumor. Most probably, I would like to get further tests done in the form of serum tumor markers such as AFP as well as beta FPG. And in addition, the first line of management for this child, considering would probably be that I would I'd like to attempt an ECV in this particular child, and also trying obtain a sample for a CSF sample for sending the serum for the CSF markers as well. And yes, so that's how I would like to proceed in this particular case.
Okay. Thank you, ma'am. So differential diagnosis that we thought apart from the pineal tumor, it was we initially thought of to be a central.
Can you hear?
Okay, sir.
Yeah, we can ask the panelist.
Yeah. So, Dr. Girish, what would you think of as a differential diagnosis, and what would be your approach to this case?
Yeah, thank you. Just a moment. I just what is the age you told again?
Sir, 15-year-old.
15 years old.
15.
15 years old. Okay. Now that we are discussing about germ cell tumors, this definitely does not fit into a germ cell radiologically, because it's neither purely pineal, because it is, of course, it's going to the posterior third ventricle, it's occupying the third ventricle, it's going into the trigone of the left ventricle and also going into the occipital horn. So I would primarily put it as one of the intraventricular tumors would be my first possibility, rather than a pineal or a or a posterior third ventricle lesion. So one of the intraventricular tumors which was being discussed, had it been a young, because in the first scan which you showed, I thought it was primarily in the CT first, I thought it was a trigonal mass. I was essentially thinking of a choroid plexus papilloma, but it is certainly not. The enhancement and all is not that of a choroid plexus papilloma, because in children that is the most common site for a choroid plexus papilloma. But again, age is little high for that child. So one of the intraventricular masses would be my zone, which you have just shown up. That would be my possibilities. Yeah.
What about a choroid plexus carcinoma? Choroid plexus carcinoma also can be considered.
Yeah, it's a possibility. But again, enhancement would be still, I would expect that in the anterior part, in the third ventricular part, it looks totally non-enhancing.
Yes.
And the posterior part also, the heterogeneous kind of enhancement is not. It's a mixed intensity lesion.
Class interna.
So, what would you be your surgical strategy for this?
Yes, now this is a little tricky one. Of course, I would go for me, it would be an approach would be an interhemispheric, anti-interhemispheric approach, and maximal decompression followed by a biventricular shunt. Or if I'm able to get a good clearance, probably without a shunt, but I am sure this child would require some kind of CSF drainage also, CSF diversion, because it is in the midline. There has to be we need to communicate both the ventricles. Septostomy, if I can manage the septostomy, we can manage with an unilateral thing. But as was discussed, of course, CSF for all other tumor markers. biopsy with maximal decompression. But if the frozen comes, as now we are discussing germ cell tumors, I wouldn't be that radical unless it is turns out to be a yolk sac or
Yes.
germinoma, something.
So what about, do you think we could do an endoscopic biopsy of that third ventricular part and then send for frozen and then
Yeah,
proceed from that?
endoscopic biopsy, yes, but as I said, with this so much of hydrocephalus, we have to. There's no way you can do a third ventriculostomy here. So definitely a CSF diversion would also be required for this child.
Yeah. So we could also do an endoscopic biopsy septostomy and then put a shunt after getting
Yeah,
it frozen.
that is
That's also a
possible.
possibility.
But again, shunt, we need to communicate the ventricles also.
Yes, with the
Yeah.
septostomy then.
Yeah, some septostomy communicate or put a biventricular.
Yeah.
Any other queries?
Just make a comment.
Yes.
Sir, if at all we are going for CSF diversion first, so would you advise shunt in this case or an ETV? Dr. Nivedita was talking about ETV as an option.
ETV, I'm not sure because the entire third ventricle is occupied, the floor of the third ventricle also. I'm not sure we'll be able to do a good ETV in this patient. An endoscopic biopsy with septostomy and a shunt would be a reasonable option. But again, as I said, that is one option. Other would be to do a decompression and at the same time do a septostomy and do a shunt.
I would like to comment on this. Looking at the image, this is not a classical posterior theoretical lesion that we discuss or talk about. It's a large lesion. The only point favoring for a posterior theoretical is the contrast enhancing component is in the region of the pineal gland. But otherwise, it's occupying the whole of third ventricle as well as extending into the lateral ventricle. So, if we did not know that this presentation is in a germ cell tumor webinar, we would think of other causes like
that is correct.
Right, that's right. Yes.
So I would really not chase for a CSF in this case because I thought we'll have the discussion later. The sensitivity between serum and CSF is almost the same. So if we had a doubt, we can just do a serum markers. If the serum markers come high, then we already know it's a germ cell tumor, and then we can think of some minimalistic approach. If the serum markers are normal, then I would rather consider surgery for decompression than just for only taking a biopsy. If a frozen comes, any germ cell tumor, then we can think intra-op. Otherwise, with such a large tumor, if the serum markers are negative, our surgical approach should be to decompress so that we can reduce the mass effect by surgery and not wait for the chemo or radiotherapy to act. That would be my plan of action. And if the serum markers are negative, I would rather consider an open surgery like Dr. Giri said, and then decompress it.
Okay, we will ask Dr. Brajlal what they did before we proceed with adjuvant therapy. Yeah.
Okay. Sir, so apart from this, we also thought of that it could be a central neurocytoma, and other differentials which for intraventricular tumors are ependymoma, atypical meningioma, or dermoid. So initial line of management, we did the right medium pressure ventricular peritoneal shunt in April 2025, which relieved his raised ICT features. This is the slightly misplaced shunt, but however it functioned well, and so hydrocephalus got relieved. And we did send for the CSF markers, and in that it was raised for mildly elevated beta HCG and alpha fetoprotein. And next
this is in the CSF. This is in the CSF.
Yes, sir.
Okay.
Next, we plan for the definitive treatment, and we, as sir mentioned, the various approaches for that has been mentioned for the third ventricular. We chose the anterior interhemispheric transcallosal approach, sir, to address the third ventricular part. And we did two-stage excision. First is anterior interhemispheric transcallosal, and second is transcortical through superior parietal lobule. So in the first surgery, the intra-op impression was white soft suckable tumors with tuft of hair and good plane of cleavage. So our intra-op impression was dermoid. And we did third ventricular and right lateral ventricular component were removed under neuronavigation and using 30-degree endoscope. However, the left occipital horn component was left in situ, and we planned for the second stage surgery. And in the second stage, we went from the superior parietal lobule, and the left occipital horn part was removed. However, the findings was slightly different. In this case, it was tumors was within the ventricles and adherent to the internal cerebral vein. In the second surgery, the tumor was slightly firm and partly suckable. However, we safely sclerotinized the internal cerebral vein, and it was excised. So the above CT is showing the post first surgery, in which we can see that the lateral ventricular part is left, and in the second, this is below CT is showing the grossly total excision post second surgery. And HPR report came as it to be a mixed germ cell tumors having all the 3 layers of germ layers, and it was having a germinoma component which was less than 5% and immature teratomatous elements. And the patient was referred to radiotherapy and chemotherapy, and as a part of the management, they did spinal MRI to look for any mets. However, it was not showing any kind of mets, and CSF cytology and tumor markers, however, it was elevated. So this was the first follow-up MRI, which was in July, which showed a query residual or recurrent mass. And patient was started on the cisplatin-based chemotherapy during that time.
Okay.
Yes.
So now I would like to call upon Dr. Rajesh, a radiation oncologist in this panel, to comment. Now, this patient now has been diagnosed with a mixed germ cell tumor, and there is a probable residue seen on the 3 months post-op post-op MRI. So how would you approach this patient now?
Yeah, first thing, we should not have waited for 3 months. That is the thing. Maybe we should have started the treatment immediately. Because it's come as a mixed germ cell, maybe we should have started with chemo first, and then plan for further management. But I would have also done an MRI spine to look for any drop mets whether it is present or not.
I think they did the MRI and they didn't find any drop mets. Yeah.
No drop mets. Yeah.
Drop mets, yes.
So what I would have planned is I would have planned for chemotherapy and then reassess with repeat imaging to see whether there's any residual left behind. If there is a residual, because it's a mixed germ cell tumor, you could have an option of repeat surgery also to remove the residual. And if it is not possible, then to plan for cranospinal RT.
Okay, so you're saying even if there is no evidence of metastasis in the spine, you would still go ahead with the cranospinal RT?
Yeah, because it's come as a mixed germ cell tumor. So mixed germ cell tumor always better to go for a cranospinal rather than a whole ventricular RT. Okay. Because a lot of evidences and meta-analysis have shown much benefit with CSA rather than whole ventricular or focal RT. If it is a germ cell tumor, maybe I would have restricted to only whole ventricular RT, not given CSI if you give chemotherapy.
Okay.
Maybe I think we should ask the opinion.
I think we'll ask the medical oncologist, Dr. Aarti. So when this patient came to you 3 months post-op with this residue, what would be your approach?
Sir, actually,
one minute. Ranjit,
yes.
Just before that, I have a query. I mean, we have two medical oncologist, Dr. Aarti and Dr. Prakruti has joined, who's managed the other case. Before this discussion, I would like to go back to the hormone tumor marker slides. With that, because by my understanding, I think these values are normal, though is marked.
No, they are elevated. They're more than 5.
And IFP 23 has elevated.
Yes, sir.
Yeah, more than 5 we consider as elevated.
No, what about I think 25 is a cutoff.
No, it's more than 5 we consider as elevated in our institution, and we do radiate them or give on the basis of that we have treated germ cell tumors.
Can I answer that question?
Yeah.
About the tumor marker. So actually, tumor markers, normally we do not find beta HCG or alpha fetoprotein in the CSF. So if we do, it should not be detectable. That's like the general understanding. So if we have some detected level, but if your alpha fetoprotein is less than 25 and beta HCG is less than 50, the chances that if it is a germ cell tumor, it is going to be germinomatous germ cell tumor. If it is beyond that, it is likely to be a non-germinomatous germ cell tumor. So to solve the entire thing, usually according to pediatric oncology perspective, we divide it broadly into two, germinomatous and non-germinomatous. So the ones who are germinomatous will fit into this criteria, AFP of less than 25 and beta HCG of less than 50. And if it is anything beyond that, whether CSF serum, we would consider by all practical means whether imaging is correlating or not. It is a non-germinomatous germ cell tumor. Now, I understand the radiology in this child, in this particular patient is not very suggestive, but there are multiple reports why the chemotherapy upfront will be beneficial. Probably the two-step surgery and the recovery and all takes a lot of time when we are actually dealing with a tumor which is finally germinomatous and it is very radiosensitive. So, which is why in terms of oncological management, the protocols have moved away from upfront surgery and we start off with neoadjuvant chemotherapy because the complete response rates with just 4 cycles of chemotherapy is about 60 to 70%, which means the dose of radiation can be required and sometimes the surgery can be completely avoided itself. But definitely the role is when you do a biopsy and if the child presents with features of raised ICP, how we manage in that scenario. So because germ cell tumor is a systemic kind of a disease, we also saw like it's not like only the risk of dissemination with shunt as it was discussed previously also. So theoretically, if we suspect a germ cell tumor, it is considered that better we avoid a shunt and we do a standby procedure for a shorter period because they are very chemosensitive. So if we have a person who's coming in with raised ICP features, if we have to do a biopsy, we get it done and we start off with chemotherapy upfront. So the response will be almost immediate. Maybe the initial period we may have to tide over with some Dexa or Mannitol, but apart from that, they respond very well to chemotherapy, especially the germinomatous arm. So it totally depends on how the radiology is. So to have a coordination is very important if we're dealing with a suprasellar mass. And if we are going to even have a mild suspicion of germ cell tumor, I think the best thing to do will be to do a simple serum marker and also a CSF if they don't have features of herniation or an impending herniation. It is best we do that and then proceed because any AFP or beta HCG detected in the CSF, it will not be considered normal. You just have to categorize between germinomatous and NGGCT subsequently.
Particular patient, after the shunt with ICS of the ventricles have collapsed, with this serum mark, with this tumor marker, would you have considered radiotherapy or chemotherapy upfront, or you would have waited for the surgical debulking and then given chemo radio as a next option?
So chemotherapy only upfront, sir, because like from all the PSYOP and COG studies, what we know now is whether it is germ cell tumor or non-germinomatous germ cell intracranial tumors, they are both quite chemoresponsive. Germinoma is definitely the more chemosensitive and more radiosensitive one, which is why we are moving towards simpler chemotherapy and lesser dose of radiation in them. But they are very sensitive tumors, which is why their outcomes are very good. Whereas the non-germinomatous arm, but in those cases, usually we'll see AFPs in thousands. So we'll never have like 20 AFP and we'll not consider there's a yolk sac component. So those are the caveats. So we have to broadly remember that it's germinomatous and non-germinomatous and the cutoff of AFP and beta HCG. And before we assume it's not germ cell tumor, a simple serum test, which can be the turnaround time is like 2-3 hours, we will have a great idea because if it is going to be in thousands, there is no doubt that it is a non-germinomatous germ cell tumor. Now, whether that has a yolk sac component or embryonal component or whether there is a teratomatous component, for treatment purposes, it makes no difference. So for us, it's only two. Germinomatous, non-germinomatous. If there is a teratomatous component, it may not respond to anything, but that is like, it's okay because it's not the cancerous part. It's the benign variant within the malignancy. So,
Doctor, can I ask something? So in this patient, after the first biopsy, if I'm not wrong, the first biopsy came as dermoid, right?
Yes.
After the interhemispheric approach.
They thought it was a dermoid.
Intra-op impression was dermoid, sir.
Not the biopsy report.
No, sir. No.
Oh, so the second,
can I answer
the two surgeries were done on.
So like after sir, yes, so like after the first surgery, like we didn't wait for the biopsy report, so we went ahead with the second stage.
It was the
So
same
we
day.
were
You
not
did same,
aware
it was
of
same day?
the actual biology.
No.
Next week.
Next week.
Oh, okay. So that's what I wanted to ask the doctor. So had the first report come, now they thought it was dermoid, but had it been dermoid, did it make a rational to go in again?
This intra finding. So actually, when we went ahead with the initial anterior transcallosal route, it was like a typical dermoid.
No, that's
So
what. So had it
we
been a
think of
dermoid,
any
had the report come as dermoid, just wanted to ask doctor. So had it been dermoid, the interhemispheric approach, the biopsy had come as dermoid, what would have been our approach for the residual tumor in the trigone?
Sir, I think surgical removal will be the best way, because if it is going to be a mature teratoma, which is what is
Then
like a
surgery is the
dermoid.
answer, right?
Yes, because we will, unless we had the information of tumor markers then, because even if AFP was 15, we will not think it's purely dermoid, because it's a mature component and it should not secrete AFP or beta HCG. So had we had that CSF information, even if the first specimen turned out to be only dermoid, then we will still know there is a malignant component sitting there. So it needs to be removed. So if we think it is only a teratoma, surgery is the key, because it's a mature element. It's not going to respond to chemotherapy. It's not going to respond to your radiotherapy also.
So, but the
in
value
this
of
case,
the beta HCG and alpha fibrillin, was it before surgery or is it after two surgeries?
I think it's pre-op.
Pre-op. After the shunt. It was after the shunt.
Yes, sir. After shunt.
So before this surgical procedure, maybe could have considered directly at that point with this values itself instead of going for a surgical option.
Yes, I think we would have also given that.
What happened?
No, I just, doctor, I just wanted to ask you, had we done a endoscopic biopsy in the first instance without doing any CSF diversion, and the report had come as mixed germ cell tumor, how long would the chemotherapy take to settle and reduce the ventricle size or take care of the hydrocephalus?
So usually the challenge for us when we see these germ cell tumors intracranial is more of diabetes insipidus than raised ICP.
No, in
I
this
don't
case,
think
there is definitely
yes.
hydrocephalus. The third ventricle is obstructed.
Yes,
So I was
sir.
just wondering, because you made a point that probably we can tide over with steroids and mannitol.
Yes.
So I was just
Yes.
wondering, had we done an endoscopic biopsy and we got a report of mixed germ cell tumor,
Yes.
how long would chemotherapy take to shrink the tumor and resolve the hydrocephalus?
Usually we see response within the first week, sir, because all the chemotherapy drugs have peak effect between day 5 and day 7. So the moment we start chemotherapy, usually because of the inflammation that will set in because of the cell kill and all, there may be a paradoxical increase in raised ICP. So always we would want to do it in the cover of DEXA and anti-raised ICP measures. But once we monitor and do that, definitely the response can be seen within a week's time.
So actually there are two components. So alpha beta protein, it takes maybe almost 2 to 3 weeks for it to come down, but beta HCG comes faster down. So
Yes,
the
they are
MMFS
because of
component
the
will respond very
half-lives.
fast.
Yes, so they are the half-life which will help us determine the response. So usually before every chemotherapy cycle, we will
We need to
assess
do
the
that.
AFP and beta HCG. But the clinical response will be different, because even here we can see it's a mixed germ cell tumor. So alpha fetoprotein response corresponds to only the yolk sac components response.
Correct.
So it's a very mixed response, but clinical response will be evident within a week's time for sure.
Sir, can I just make a comment?
Yes.
Yeah.
Last comment, and then we'll go on to the next case.
Yes, sir. So, like in this, during
how
his
was this
first
patient managed after this?
Pardon, sir?
No, this patient, did you send him for RT or chemo after this?
Yeah, okay.
No, Dr. Karthikeyan, the question is, in July 2025, did you send this patient for RT or chemotherapy?
Yes, we had said, Mansell, just go ahead with your slides.
Yes, sir. So patient was started on cisplatin-based therapy, and this was the MRI. And after patient was on that therapy only, and patient after 1.5 months presented with altered sensorium and right-sided weakness in E2V2 M5 status and right hemiparesis 2/5 is the power. And this was in September, and this is the second follow-up MRI. This is showing a mass which has grown proportionally larger than it was previously, and with the cyst. This is the sagittal image, sir. And however, the patient refused to for the admission, and didn't go, but now we have now we are with the dilemma whether to go for the redo surgery or continue with the adjuvant management in TSS. This is the
Did the patient take the chemo radiotherapy at all, or
cisplatin. Patient was on chemotherapy.
No, has he completed the course of chemotherapy? Or?
No, sir.
Sir,
Not sure about
patient
that.
was just started on treatment, but within a few weeks' time, he had come with altered sensorium. It's such a drastic, large size of tumor. So after that, I mean, patient was not keen on any continuing further treatment. So the interesting point is that within few months' time, the tumor has really grown up to a disproportionately large size. I mean, I just want some comment from experts. I mean, is it the common cause or something abnormal in GCT? Such a
between
rapid.
the surgery and this tumor growth? What is the
6
gap
months.
between the surgery?
6 months.
6 months is a fairly
No,
large
so,
gap. From the surgery
the
to this
initial
growth.
surgery was in. So the initial surgery was in April. So the scan which is showing is in September.
5 months.
5 months.
Yeah.
Can I answer?
Yeah, Dr. Aarti.
So actually, like one thing with the pediatric tumors are they respond very well and they grow also equally fast. So it's actually even the recurrent germinomas, especially if this patient is chemo naive and has not received proper radiation, there is still some scope to treat. So it is good that we will start off with a intense chemo intense regimen so that we don't buy any more time, because in pediatric tumors the crux of treatment lies in local therapy and not delaying chemotherapy. So that is also one of the reasons why we started off, like all the PSYOP and the COG guidelines suggest starting off with chemotherapy, because recovering from a major surgery is going to take a long time and it is going to delay the systemic part of chemotherapy, which is an important component. So if the patient can be convinced for a systemic chemotherapy, and we can still give high dose chemotherapy in the form of cisplatin etoposide and ifosfamide, or ifosfamide etoposide alternating with cisplatin etoposide, and if the child goes into radiological remission, you can plan for even high dose chemotherapy, which will help in pushing the child further to shrinking of mass, which can be operated or can be radiated, because germinoma we know is a very sensitive tumor. One thing I would also want to consider here is, because we had a teratomatous component, growing teratoma syndrome is real, and it is sometimes a definite complication which we see. We might have treated all the other part, because as we already discussed, the malignant part will respond to your chemoradiation, but the teratoma part is going to sit there and suddenly it can grow in size, which can be managed only with surgery. So, but biopsy is not going to be the answer, because different parts of the germ cell tumor is going to have a different biology. So we can probably redo an AFP and beta HCG, which will tell us if there is a malignant component. We can also look for it in the serum levels. But of course, what was only germinoma before is not going to have a non-germinomatous transformation. But our concern here will be whether the germinoma itself has relapsed, or whether we have the teratoma component which is growing, because we are not sure about whether the child received chemotherapy or radiation. So probably tracking on to what they received and doing the tumor markers in CSF and giving a trial of chemotherapy. If it is really only GCT which has relapsed, it will respond to chemotherapy. At the end of 2, if you see there is no response, I think we'll have to consider if it's only growing teratoma syndrome, which is the teratomas growing in size, which can be tackled only with surgery.
I think there are 2 points. One is I think we are running short of time. We have to wind up in 2 minutes. The one is there has been a gap between the surgery and starting of therapy. That is the reason enough for it to grow. Now the patients come in altered sensorium. We have 2 options: decompress the tumor, reduce the mass effect, and start the chemotherapy as fast as
Early as
possible,
possible.
provided
Yes, sir.
as early as possible, provided the patient family agrees to it. Otherwise, we are in a fix what we can do for it. I think we have to wind up this case. There are few comments on the comment box.
Yeah.
Dr. Ashwini has asked the question whether in the first place was it possible to do a single surgery to remove both parts. I think the answer would be no. I can Dr. Girish can comment on that. And like I said before, if the markers are high, there is always possibility of giving chemotherapy to tumor and then consider for a Dr. Girish, do you think one approach would have helped the whole trying removal of whole thing?
Dr. Rajesh, can you please mute yourself?
Can others unmute, please? Can others mute? I think Dr. Girish is not audible. Next, we have a doctor. We are happy Dr. Jogi Patisapu has joined us from US. He is also. Am I audible?
Audible.
Yes, sir.
Yeah. So we are happy Dr. Jogi Patisapu have also joined us from US. Welcome, sir. If you are online, you can actually comment, sir. You put a message in the comment box. You can unmute yourself and make a comment, sir. Dr. Jogi.
Thank you so much. This is Jogi Patisapu. Namaste to everybody. First of all, congratulations. Very nice job. I'm proud to hear the comments and the thinking. All of you are really, really putting in extremely good thinking going forward. A few comments. I'll date myself by taking myself back to Alex Sanford, my mentor, 1984, when he first came back from those days, the POG, Pediatric Oncology Group meeting, said, look, we're going to use chemotherapy for brain tumors. We all laughed at him back in 1984. I have spent much time with Roger Packer in Philadelphia. Friends, I want the younger people in this audience to understand 2 points, very important points. Tumors multiply very fast in children, as Dr. Arthi pointed out. You can take out 90% of the tumor, we feel good about ourselves, but the doubling time within 3 or 4 cell cycles, the tumor has come back very quickly, as you see in this 15-year-old boy. Therefore, we as surgeons should be very careful about saying we did a good job of taking out a lot of tumor. In pediatric neuro-oncology, my limited experience and my interest in this topic tells me chemotherapy, CSF markers, and other forms of management are taking a very, very important and a very positive way of managing these things. Surgery has become slightly less important, although extremely important for management of ICP, hydrocephalus, etc. In this particular case, I was wondering if the front part of this lesion could be cystic. Therefore, at the time of initial biopsy and decompression, could the cyst be drained? Could a septostomy be accomplished? Could a ETV tried with success? And possibly even leave a Amaya type reservoir for emergency drainage or decompression or more biopsies as necessary. And we would do the upfront craniospinal imaging. And once the tumor markers have come back, upfront chemotherapy makes our job very much easier when we go back and operate. The tumors bleed less, they're smaller, the margins are a little bit better defined. And I have found that upfront chemotherapy, 2 or 3 cycles prior to attempted debulking, is a good option. In this particular case, I was surprised that you went ahead and tried to debulk without the biopsy results. I was wondering why. And your approaches were beautiful. You did accomplish what you wanted to. One would argue, could you have done more because you had a lateral extension? Different approaches to the pineal are available. Each one is very complex, but it's very good. Management was done well. Surgical techniques were beautiful. Unfortunately, the tumor came back very quickly, probably because of inability to administer chemotherapy very early, which only thing I want the younger people to understand, it's a multidisciplinary approach. Please, let's include others who can help the patient as much as we can as surgeons. Thank you so much for listening. Appreciate it. Namaste.
Thank you for your very insightful comments. We'll go to the next case. We are running short of time. Dr. Niveta, you can make it fast and short. Dr. Nivedita?
Good evening, everyone. I'm Nivedita.
You can share
yes,
your
sir.
screen. Your screen is not visible.
Yes, sir.
The screen is not visible.
Yes, sir. Just a second.
Are you having a problem in sharing, Dr. Nivedita?
Yes, sir. It's not accepting the share. So just give me 1 minute. So I will sort it out. I'm sorry.
Santosh, can you help?
Are you able to see the share screen button, Dr. Nivedita? Yeah.
Yes, sir.
Nivedita might need some help in sharing the screen.
Nivedita, otherwise I will. Yeah. Are you able to share the screen?
You can see that green color arrow of a share.
No, I think she recognizes that, but I think she's not able to. It must not be some compatibility issue. She may have to reboot. Yeah.
I am sharing the
Okay,
screen.
got it. Yes.
Yeah. I think.
Yeah.
This is I am sharing the screen.
Okay.
Is the screen
Dr.
visible
Rajji.
now?
Yeah.
Nivedita is there.
Yes.
Is the screen
Visible.
Visible.
Presentation
Yes.
mode, please. Presentation mode.
Yeah.
Yeah, great. Excellent.
Yes, sir. Sorry, sir.
You can proceed.
So,
I will
yes,
move
sir.
the slides. You proceed.
So no, sir. It's fine, sir. I think I need to share. No,
I've already shared.
No, it's already shared. Nivedita, you start presenting.
Yes.
Are you able to see the slides in your place?
Yes.
Now we are.
So good morning, sir. Sorry, good evening, sir. Good evening, all. I apologize for the delay. So today the presentation is on germ cell tumors. I am Dr. Nivedita. I'm post-MCH senior resident in Department of Neurosurgery, Human. So in today's case, we're discussing, we will name the patient as Master SS. He was a 12-year-old male who presented to us with complaints of headache as well as vomiting since 1 week and diplopia since 1 week. There was no associated complaint of fever, neck rigidity, vision loss or blurring of vision. There was no complaint of any weakness, imbalance, dysphagia or hoarseness of voice or evident facial deviation. His antenatal as well as perinatal history was also normal, and there was no history of any consanguineous marriage in his family history as well. Coming to the examination, on presentation, the patient was conscious and oriented. The GCS of E4, V5, and 6. This was a bilaterally equal and reactive. Accommodation reflex was positive, and he had and his visual acuity was 6/6 bilaterally. However, he had grade 4 papilledema, and he also had bilateral 6-nerve palsy. He also had bilateral upcase palsy on evaluation. He had no motor or sensory deficits, and on examination, patient did not have any cerebral positive on presentation. This was the initial scene on presentation. So here we can see that there's a posterior third ventricular lesion along with upstream dilated ventricles. Yes, sir.
Yeah, please go ahead.
No, continue.
This is the initial CT on presentation. Based upon the CT, in view of the presence of dilated bilateral lateral ventricles and the hydrocephalus as well as the effacement of the sulcine gyri, we decided to proceed with a ventricular peritoneal shunt for this child. So we did a right fascia shunt, and the CSF cytology shows lymphoid cells. Glucose was 73, protein as well as lactate were in the normal range, and hence it is now, we considered it as non-infective. And we decided to proceed with tumor markers as the lesion was present in the posterior third ventricle in the final region. So that showed an elevated value of AFP, and the AFP value was 50.56. We also decided to proceed with an MRI, and this is the MR imaging. So to begin with, this is the axial T2 imaging, which shows the presence of a posterior third ventricular final region lesion, which is sorry, is it visible? So the axial imaging basically shows a posterior third ventricular lesion, which is T2 hypo, and also it shows a shunt in situ as well with considerable decrease in the hydrocephalus. This is the sagittal imaging of the same patient. We also did a contrast imaging as well for this particular patient. And this is the contrast imaging, which shows a heterogeneously enhancing lesion with a cystic component, which is present in the posterior third ventricular region. And this is the coronal section.
Okay, question to the panelists. What will be the next plan of action? This is a young boy who underwent initially we thought it is a benign lesion, probably cytoma or something, because I'm cutting the discussion short because we're running short of time. So we just did a shunt. We put on a ETV or since patient came with raised sensitivity, we did a shunt and then did a serum marker, and then serum markers and MRI. So serum marker shows high AFP level, and MRI shows collapsed ventricle and the lesion. So what would be the next plan? We already discussed this in the previous case.
So MRI spine has been done, sir. MRI spine.
Dr. Prakriti is there. Dr. Prakriti is a is an oncologist.
MRI spine, whether it's been done.
So in this particular
that is done. We didn't put that. That did not show any drop, any drop lesions.
Since we have a CSF showing, which is showing alpha fetoprotein is very high, and location is penial, maybe we can take it as the non-seminomatous germ cell tumor and chemotherapy first.
The serum alpha fetoprotein is very high.
So serum alpha fetoprotein was elevated, so it was 50. So.
Yeah, so that's what we did. Dr. Prakriti, are you there?
Oh, I guess in this approach,
Sir,
ETV and biopsy would have been better.
So I don't remember the exact values, but this child's serum AFP levels were quite elevated. Am I audible, sir?
Yeah, in one of the slides, I think she had put the values previously.
Yeah. So since the values were more than
50.56, which is above the cutoff.
So we did consider this child as a case of non-germanomatous germ cell tumor and went ahead with chemotherapy.
Yeah, so this child underwent 3 cycles chemotherapy. Dr. Nivetha, you can continue. So this was the MRI after. Go ahead.
I was wondering, Dr. Ranjit, I was wondering, would ETV and biopsy would have been a better option? We could have than a shunt and.
Yes, sir. That would have been a better option.
That would have been a better option. Yes.
That would have been a better option, but my way of looking at it, usually when we see one is this when the child came, the child had only a CT, which showed a small lesion with multiple calcifications. So our thought process was it's a benign tumor, and therefore if it was benign tumor like pinosarcoma, my understanding would be to consider a resection. So we did a shunt and then consider because like we said, the initial differential diagnosis was not a thought process of germ cell tumors. But of course, if we had an MRI and if we had a serum marker, With serum marker, probably only ETV would have been sufficient. Even biopsy may not have been required, but we could have avoided a shunt by doing a ETV biopsy. But after shunt, we got the serum markers and that showed high. So this child underwent chemotherapy. After 3 cycles of chemotherapy, this is MRI.
So the child underwent 3 cycles of chemotherapy, a carboplatin as well as etoposide, and repeat MRI was done. And we followed up with the child after 3 cycles of chemotherapy in our OPD. So this is post chemotherapy after 3 months. So this basic. So I will. This is the sagittal MRI, T1 post-contrast sagittal MRI. So the lesion actually showed an increase in the size. There was an increase in the size of the lesion post chemotherapy.
What are the serum markers now? Serum and
yes, sir. I'm going to show the same.
These are the serum markers are elevated.
Even now.
Serum markers were elevated, sir.
No,
So
the
this is
serum markers normalized after chemotherapy, if I'm not wrong.
And the serum alpha-fetoprotein had increased from 50 to nearly 76, sir, in the follow-up as well. So based upon the further increase in the alpha-fetoprotein as well as also the increase in the size of the lesion,
Why
I would
was
like to ask the
AFP
panel
being
what
done
their
every
plan would
day?
be next, sir.
In the previous scan, previous slide, AFP was being done every day.
No,
The previous
not
slide.
every time. That was the wrong.
We do AFP after every cycle, sir.
No, she has written wrongly.
Oh, okay.
So,
Dr. Prakriti, you
in
can
view
come
of
in.
the increase in the tumor size as well as also the persistently elevated alpha-fetoprotein levels, we decided to proceed with surgery for this particular child, sir. And prior to surgery, there was a duration of about a month or so in which the child again received further chemotherapy. And this is the MRI again, which is repeated just prior to surgery. This again showed a further increase in the size of the lesion as well.
Dr. Nivetha, can you hear me?
So in this particular case, we decided to proceed with definitive surgery. And the child underwent a left-sided parieto-occipital splenotomy, occipital transplantorial approach, and decompression of the lesion. So during surgery, our findings were that the lesion was centered in the posterior part of the third ventricle and superiorly it was stained by the vein of Galen as well as also by the vein of basal vein of Rosenthal, and inferiorly the cerebellar vermis was displaced by the lesion. In the superior half, the lesion was cystic. It contains fat as well as keratin flakes, and inferiorly, it is solid and filled with pearly white fur material, which is very similar to a dermoid, sir. The intraoperative impression was that of a dermoid, and there was no invasion of the surrounding parenchyma, and there was a very good plane of separation between the tumor as well as the surrounding parenchyma, sir. So this is the immediate post-op CT which was done following the surgery. So the post-op CT basically showed no residual lesion, and the pathology report, basically the frozen section of the squash which was sent intraoperatively showed a teratoma or query dermoid, whereas the final pathology report was finally a mature cystic teratoma, which showed mild nuclear atopia as well, embedded in mature neurogliostroma along with melanin pigment, and there were also areas of hemorrhage and dystrophic calcification were also seen, sir. So based upon this pathology report, sir, I would like to ask, would there be a further role for any adjuvant therapy in this particular patient, sir, based upon the biopsy report that we had obtained?
Dr. Aarti, would you like to comment?
So definitely we'll have to consolidate with chemotherapy. Otherwise, the recurrence rates will be very high, and radiation also has to be given, because the approach is like, it's actually great that we have been able to achieve a complete resection in this child, which was progressing. It's actually hard to believe the histopath report, which says only it's a teratomatous component, because for all practical purposes, if we see elevation in tumor markers, somewhere or the other, the yolk sac component is there. whether it has been isolated or not. That's the main purpose of monitoring tumor markers itself. False elevation in tumor markers and all, it's possible, but here we have documented increase in size also and increase in tumor markers also. So we have done the second look surgery, which is great, but if we don't consolidate, definitely there's going to be a recurrence. So we'll have to give chemotherapy and also radiation. And if we are going to upfront consider it as an NGGCT, craniospinal irradiation also should be a part of the treatment, sir.
So one question is like whether there could be an extra cranial component present which has not been detected. Not sure of that. If there is
That's interesting. We should probably get a PET done, but usually we don't see intracranial germ cell tumor with an extracranial metastasis.
I mean, we have a
There is a
situation like
possibility
this.
there is a very small met somewhere along the spine, and which is not from this therapy. This only is a hypothesis. I don't know how we can explain it, but
So definitely,
how
I
we
would
did
have
not
considered
detect.
CSI for this patient after the
Yes,
chemotherapy
we
is over,
have to, I think.
rather than a
Yes.
focal RT.
Yes.
Dr. Prakriti,
what did you do?
Yeah,
Dr.
that is what
Prakriti?
we also. Hello, sir, am I audible?
Yes, you're audible.
Please go ahead.
Yeah. So because the tumor markers were elevated, we still went ahead and treated this child as a non-germanomatous germ cell tumor, though the biopsy was suggestive of teratoma. The thought process was probably it was a mixed germ cell tumor where the non-germanomatous components had resolved with the chemotherapy, and probably the teratoma was the one which continued to grow. So we then consolidated this with chemo and RT, sir.
Okay. So I think they have given chemotherapy and CSI for this patient after diagnosis.
This patient received radiotherapy. I'll just go to these are the follow-up scans. After I'll go to the last slide, last scans. We have followed this child now for more than a year. This is a follow-up scan at 15 months.
Yes, sir. Follow-up showed no residual lesions, sir.
This is a follow-up scan at 15 months. The child is now asymptomatic. At 1.5 years, there is no residual recurrent tumors. The post-therapeutic lesion is clear of the tumor, and the child is doing well.
Yeah, great to hear that.
Okay.
Great.
Thank you. I think we'll go to the next talk.
Yeah, so the next so that is a very good case. So I think what we learned from both these cases that both the in germ cell tumors, once you detect it's a non-germanomatous germ cell tumor, particularly we need to initiate early chemotherapy, so because that may help in controlling the tumor. And in case the chemotherapy doesn't work, the second look surgery may be beneficial in establishing a diagnosis and then following it up with further adjuvant therapy.
The point we learned from this patient is we thought this tumor will respond immediately. That's why after the marker we had. But three cycles later it was increasing. So then there's no point in waiting for chemo to work. Then we step in and do surgery. And after surgery, though we got a mature teratoma as a biopsy, we discussed among same tumor board, and then we thought even though the biopsy is mature teratoma, there should have been a non-germatomatous component which has given a raised AFP level, so that may not be controlled only with surgery. So the adjuvant radiotherapy was also given, so that all the components of the tumor are taken care. So that is a turning point for the case, that we have to employ all the modalities available to have a good control. Thank you.
Yeah. So we will now move on to the last talk, which is Dr. Ved Prakash Maurya from SGPJ Lucknow, and he will be talking to us on algorithm-based approach to management of germ cell tumors and adjuvant therapy. Dr. Ved,
yes,
we
sir.
Can see your slides.
Am I audible, sir?
Yeah, you're audible.
Good evening,
Please
everyone. I thank INDSPN webinar committee for providing me this opportunity. My slides are visible, sir?
Yes, they're visible. You can go ahead.
Thank you. So I will be talking about the algorithm-based approach for the management of germ cell tumor. I think most of the things have been discussed, but still I will present myself. So this is the management algorithm which I will be discussing. So as Dr. Tarang Bora and my two case presenters, they have discussed, and the panelists have very well pointed out that there is a role of clinical examination, radiological examination, and measurement of the tumor markers. Then identification of the hydrocephalus, tumor marker status, how much they are elevated, whether to do biopsy or not, ventricular drainage, when to do endoscopic third ventriculostomy is preferred over ventriculoperitoneal shunt for obvious reasons to avoid the dissemination. So these CQ are the clinical questions. So there are total 10 clinical questions which I will try to answer in the presentation, and that will be able to define the algorithm what we are practicing. These I have taken from Japanese and European guidelines. So first is measurement of tumor markers essential in case of CNS GCT. There is no doubt. This is the grade 1A, means level of recommendation is 1 and strength of evidence is A. So there is no doubt there is obvious need for the measurement of CNS germ cell tumor. The tumor markers should be measured. Just reversing, everything has been discussed. Tumor markers are useful to differentiate between tumor progression and growing teratoma syndrome, as very well pointed out by Dr. Aarti during chemoradiation therapy. So the markers will be subsiding, but tumor will be growing. Is histopathological diagnosis necessary in this GCT? Obviously, when GCT is suspected, histopathological diagnosis is recommended to achieve a definitive diagnosis. There are guidelines if the markers are severely high, like SCG more than or equal to 2000, AFP more than or equal to 2000 nanogram per ml, both clinical courses and imaging findings are typical, then there should be indicative that this is the germ cell tumor. Aggressive resection of germinoma necessary? Obviously not, as we have very well discussed in the last talk. So chemotherapy is effective against germinoma. The aim of surgical intervention is to obtain a tumor specimen, allowing the histopathological diagnosis rather than aggressive resection. There are guidelines which hold that biopsy, not aggressive resection, is recommended. So histopathology is thus important to minimize the risk of dismissing NGGCT, non-germinative germ cell tumor components, and the more malignant findings point to the appropriate diagnosis and treatment. Is surgical resection of non-germinative GCT necessary for mature teratoma? Obviously, yes. Other than that, chemo and radiotherapy is recommended. Tissue after chemotherapy, usually teratomas, non-neoplastic tissues, tumor growth during chemotherapy with normalization of tumor marker levels is growing teratoma syndrome, as I very well said. Fifth is surgical intervention necessary for CNS GCT associated with hydrocephalus? Surgeon intervention such as ETV is strongly recommended to overcome the hydrocephalus. As I said that there is biopsy for supracellular and pineal regions, safe, effective measure, and to avoid ventriculoperitoneal shunt and dissemination of the tumor. Are chemoradiotherapy necessary for germinoma? Yes, definitely. Radiation therapy covering the whole ventricle, that is whole ventricular irradiation, together with chemotherapy is strongly recommended. Prophylactic spinal radiotherapy is not recommended for germinoma without spinal dissemination. Treating germinoma with chemotherapy is strongly recommended against 1B, means chemo as well as radiotherapy both are recommended. Radiotherapy in germinoma, as I said, it is recommended. Now there are several studies and trials going on, as ma'am said that SIOP CNS GCT2 clinical trial and completed Japanese clinical trial both used 24 gray whole ventricular irradiation as standard. This is considered the maximum tolerable dose for hypothalamic pituitary system. Craniospinal irradiation and 5-year disease-free survival at a rate of germinoma exceeding 90%. Limited reports are still available. So regarding spinal cord recurrence without prophylactic spinal radiotherapy, progression of germinoma into spinal cord is considered almost absent. Chemotherapy in germinoma, clinical trials usually employ platinum-based combination therapies, as very well pointed out by the panelists, and with or without alkylating agents such as ifosfamide. Chemoradiotherapy effective for NGGCT. They are strongly recommended for NGGCT with excluding the mature teratoma, level 1B evidence. In Japanese study, NGGCT encompasses all GCT except pure germinomas. In contrast, the same terminology is used, slightly different fashion for the COG and COP. as it was discussed. In the Japanese clinical trials, they historically treated GCTs other than germinoma differently as either intermediate risk or high risk. For high risk, crinospinal radiation with combination chemotherapy with platinum-based chemotherapy agents, and the radiation field in the treatment without spinal dissemination is still a controversial topic of our debate. And for intermediate risk NGGCT, which often represent with mixed GCTs with a germinomatous component, whether local radiotherapy is sufficient or whole ventricular radiation is necessary, requires further investigation. Different treatment strategies may be necessary for this category of patients who are more vulnerable to intense chemoradiotherapy. Now, for recurrent germinomas, is salvage treatment necessary for recurrent germinoma cases? Treatment aimed at disease cure is strongly recommended. There is strong level of evidence. The recurrent germinomas reportedly curable with salvageable therapies, according to descriptive studies based on case reports, series, and retrospective analysis only. While such reports have shown significant of conducting salvage treatment during recurrences, standardizing treatment has been a difficult task. So there is a report which suggests that high-dose chemotherapy did not cause serious adverse events or drastically impair the quality of life, but the reported cases were small and standardization of treatment for recurrent germinoma yet to be achieved. This is still a topic of debate. Is salvageable treatment effective for recurrent NGGCTs? Remission-oriented treatment is recommended, but palliation treatment is also recommended when treatment response is not unfavorable. Means if it's not favorable, then we have to go for palliation only. The prognosis of recurrent NGCT is undoubtedly severe compared with recurrent germinoma cases. Even fewer reports have reported that salvage of recurrent NGCT cases is there. There is a study and clinical trial using high-dose chemotherapy for 11 treatment-resistant or recurrent cases. 4 cases achieved disease-free survival, and all such cases had seen clinical remission following the chemotherapy. These studies, they concluded that clinical remission following chemotherapy was most important for the prognosis. Salvage treatment for NGCT at the time of recurrence can be affected by treatment, particularly radiotherapy regime. Even with high-dose chemotherapy, remission is achieved only infrequently. This shows that still the quality of life needs to be treated in a better way. What is the long-term prognosis? So the clinical question 10 is follow-up necessary for CNS GCT cases? Follow-up for as long as possible is strongly recommended. In general, it is recommended that patients should be followed for a period of at least 5 years after the end of the treatment with imaging, serum markers, and clinical examination. Since the recurrence of germinomas may occur later in the course, they require up to 10 years of follow-up. While NGCT relapses are seen more frequently in the first 2 years after treatment, but children with intercranial teratomas, they should be followed up every 3 months in the first year, including all the parameters like clinical assessment, serum markers, and radiological assessment. These are my acknowledgement. I acknowledge my department and these 2 study groups from where I have taken the protocol and try to discuss this topic. I will just touch upon the surgical options to access these lesions. Endoscopic as well as microneurosurgicals are the options, as well as very well discussed in the previous 2 cases. So ETB and biopsy is the workhorse in such cases, but we should be aware while taking the biopsy because many a times these lesions are vascular and they may bleed. And that in that case, it may bleed and the tumor bleed may lead to significant expansion and clinical deterioration. This is the case where we took the biopsy and it bleed and expanded. Pretty simple procedure we can do. A standard precordial burr hole, identifying the landmarks, memory body, basilar artery bifurcation, Fogarty catheter. First ETV, then taking for the biopsy. Supracerebral infiltratory approach indications, as we have very well discussed in the cases, dorsal midbrain lesion, pineal region lesions, tentorial and insusural lesions. So we can use microscope as well as endoscope. Advantage and disadvantage are obvious. Must be achieved by external ventricular drain because the space is constrained. We can insert a lumbar drain, endoscopic third ventriculostomy, tapping the tumor cyst, and CSF tapping from the cisterna magna. This would be the position, operative setup, craniectomy followed by dual exposure. Then we can proceed further, taking the biopsy. Another approach we can go for such lesions is gravity assisted retraction-led occipitotranstender approach, where we have to navigate in between the tentacles of the veins. We have named and published the tentacles of the pod. We have to look for the alignment of the vein. If the internal cerebral vein is compressed with the tumor mass, then we can easily go and take out the tumor. Otherwise, there is plus minus. If we can safely go and take out the tumor, it can be done. So this would be the position for Garrot. These are the operative setup where the patient is positioned. Transverse sinus, superior sagittal sinus is exposed and tumor is taken out. Advantage, no retraction of occipital pole, wide exposure, opening of the cisterns, utilizing the distorted venous anatomy, establishing the CSF path. So CNS germ cell tumors are rare, but they are challenging. They require multimodal therapy, neurosurgeons, medical oncology, radiation oncology, neuroradiology, as well as pathology, and surgical decisions should be decided judiciously. Thank you for your patience listening. Today is World Anesthesia Day. We should not forget our anesthetists who accompany all the way in the OT. Thank you very much.
Thank you, Dr. Veer. That is a good summary of the discussions that we had. So there was one question, I think, by Dr. Tarang, whether we should give whole ventricular radiation always for germ cell tumors, or when we should restrict it to focal RT. So Dr. Rajesh, I think he's not there. I think Dr. Aarti has answered it. Would you like to tell it to the group, Dr. Aarti?
Yes, sir. So like whole ventricular irradiation is what is always followed because of the patterns of recurrence mainly. So based on the older studies, what they have found is in germanomatous, if they were giving only focal art, even if the dose was higher, which was almost 50 gray to begin with, now we have come down to 40 gray. But even if a higher dose is given, but if it's only focally given, the recurrence used to happen in other parts of the ventricle. So whole ventricular RT is always included. If there is a residue after a particular number of neoadjuvant cycles, the focal boost also will be given. But it is not, focal RT is not discussed at all, sir. Whole ventricular irradiation is what is required. And all the non-germanomatous GCTs will always require craniospinal irradiation. Yes.
Ma'am, can I ask a small doubt?
Yes, sir, please.
Regarding irradiation of the tumor bed, in
Yes,
addition to the whole ventricular irradiation, we will give additional radiation to the tumor bed, or it will be covered in the whole ventricular irradiation?
Sir, it depends on the radiological response after cycles of chemotherapy. So if it is germanomatous, the usual protocol is 4 cycles of chemotherapy and then we do a radiological assessment. So if it is complete remission in that, then we can just give whole ventricular radiation and only residue will get that additional focal boost. So there is no concept of additional to the bed, sir.
Okay.
So 24 with whatever the residue that gets like additional, it's total of 40 we give. So 24 plus 16 is what is the usual volume that is given. Any radiation oncologist can throw more light into it. And the boost volume, it increases to 18 to 24 depending on how much residue is left behind.
Okay.
Otherwise, the whole place will get a 40. The whole ventricular will be 24. Sorry, the initial thing will get a 16. So the 40 will go to the initial tumor volume. 24 will be to the rest of the whole ventricle, sir. So the tumor bed will get, sorry.
Tumor bed will get additional.
Yes, it will get. The initial volume will get.
Yes, ma'am.
Okay. I think there are no more questions. So I think we have come to end of this webinar. I would like to thank our panelists, Dr. Aarti,
from any of the participants?
No, I think there were no more questions.
Dr. Kaushik is there. I think we can ask him. No, Kaushik still has joined. We can ask him to. Kaushik,
Dr. Kaushik Seal. Yeah, Dr. Kaushik Seal, please, you have any
is
comments?
Dr. Kaushik there? Not there.
No, sir, he is
Dr.
not.
Kaushik.
No, I think he's not there.
No,
He
sir,
was
he is
there.
not here.
His name
Not
is in.
active.
Yeah.
Ranjit, I think we can.
Yeah.
Yeah, Ranjit, I think we can. Dr. Girish,
So I would like to thank our panelists.
any comments? Final comments? Dr.
Hello.
Girish,
Hello,
Yeah,
Kaushik.
Dr.
Please,
Kaushik
please.
is
Yeah, yeah. Any
बोलिए
comments? Any comments, Dr. Kaushik?
नहीं this was a very well designed and good webinar with very lot of informative components. I thanks all the participants on behalf of INDSPN. Would continue organizing this, and Ari and Ranjit are doing a great job, and we'll probably come back in somewhere middle of next month with
Yes.
another interesting topic.
Yes.
I also thank the DigiNeuro people for hosting this webinar. So thank you all and good night.
Yeah, I would like to wish all doctors, neurosurgeons, and oncologists, oncosurgeons a very, very happy Deepavali from Health and EU.
Thank you and wish you all the same.
Thank you, sir.
Thank you so much. Happy Deepavali to you, and thank you for giving us an opportunity to carry this webinar. Thank you.
Thank you, Ranjit, sir,
Yeah.
for giving this
Thank you,
opportunity.
Ved, Tarang, Dr.
Thank you,
Girish,
sir.
Dr. Aarti, and Dr. Rajesh for joining.
Thank you.
Yeah. Yeah.
Thank you. Good night, Girish, sir. Good night.
Good night. Good night. Good night.
Very good.
Bye, Tarang.
Yeah. Good night. Yeah.